All right. Again, morning. So my presentation, perforated gastro-duodenal ulcers, and then my attending was Dr. Bell for the presentation. The case comes out of the clinical scenarios book with a few modifications to kind of steer it towards the direction Dr. Bell and I had talked about last week now. But in general, we're consulted by the ED in regards to a 70-year-old male who has approximately 10-hour history of abdominal pain. Per the ED provider, he has no abdominal surgeries. His vital signs are as listed. Only concerning vital sign is his heart rate at the upper limit of normal, otherwise within normal limits. And they have put in some labs and imaging, however, they haven't resulted yet, and they'll call us as soon as those are up and ready. We head on down to the ER, take a look at our patient, and what he tells us is that he can specifically remember the exact moment at which he had this abrupt left upper quadrant pain just under his ribs that radiated to his shoulders. This is what brought him to the ER. However, while in the ER, the intense pain that he had that brought him in started to become more diffuse and less intense across the abdomen. Otherwise, since he's been in the ER, he's had bowel movements, past gas. He states that somewhere in his past, he remembers having some pain similar to what he had, not as severe, but he remembers his primary care provider giving him some medications, and it addressed the issue. Otherwise, the only other medical history that was relevant is he has this chronic NSAID use for his low back pain, and then aspirin use. No family history of cancers or anything like that. And on physical exam, it's benign until you hit the abdominal exam, in which you find he's guarded, diffusely tender, and then you note this tenderness to the right lower quadrant. And so some points to touch on in regards to the history and physical for our patient here. The literature talks about 3 phases of patient presentation based on time for perforated peptic ulcers. And so the first phase or early phase is within this 2-hour window in which a patient talks about a specific set of specific time at which they are able to recall this pain occurring. And again, that's within this 2-hour time frame. And often what they note is they have some radiation to the shoulders with this pain starting. After that 2-hour window, from a 2-hour to 12-hour window, they notice that intense pain becomes more mild and then becomes diffuse. And this is going to be in relation to the succus. And so that's also what we find in our physical exam is this patient now has right lower quadrant pain, and that's the dependent succus going to the right lower quadrant manifesting as Valentino's sign. And then there's the late manifestation. So unfortunately, if a patient hasn't been intervened upon after this 12-hour window, they develop this shock-like picture, become febrile, hypovolemic. If they haven't developed nausea and vomiting, they begin to develop it, and then it progresses the longer the patient hasn't been treated. Other components are the patient's chronic NSAID use, and so kind of getting into that with the differential. So we've gone down, we've taken a look. I've touched on the patients in 2 of 3 stages. He's had the early stage. He is now sitting in that late intermediate stage, and we're here to intervene. So if we don't intervene, he would progress to that late stage. Otherwise, concerning features are he's got that chronic NSAID use, and then what sounds like a history of a past ulcer that was treated by his primary care provider. Something we don't know in regards to this gentleman is his current H. pylori status. And that'll be something we touch on a little bit later on a different slide. But things that we can't forget to think about or look at is this secondary to some kind of cancer, maybe gastronoma or something like that. And so we'll touch on endoscopy a little bit later as well. We had a presentation last week by Dr. Robick where he talked about SMA occlusion and mesenteric ischemia. And so this gentleman's not presenting with that pain out of proportion. Again, that's patients coming in, screaming, writhing in pain. You go to do your physical exam and you find that they're soft, maybe mildly guarded. It just isn't correlating with the level of pain they're presenting with. And then small bowel obstruction. And so I tried to minimize the presenting symptoms or associated factors that would suggest a small bowel obstruction. So no surgeries. He doesn't have nausea or vomiting at this time. Cancer could be something as a potential cause of hernia, but we didn't identify a hernia on physical exam. So moving down on our differential. So then moving forward.
Hold on a second.
Go ahead, sir.
Let's see who's on. Alex, what's another differential? Go back to your differential side. What's another one that is would be high on there of this type of pain that you would want to think of?
Pancreatitis.
Exactly, pancreatitis. You can, if you don't have any imaging, sometimes these look and present very similar.
So continuing, so topic of the presentation obviously is, perforated peptic ulcer, gastric ulcers. So we want to make sure that we properly identify, the types of ulcers. And so if you remember, there are the 5 types, 1, 2, 3, 4, 5. And then there's the rhyme or scheme that I guess people use to remember it. 1 has 1 ulcer, 2 has the 2, 3 is pre, 4 at the door, and then 5, there are 5 letters in NSAID, or it's the one that doesn't rhyme very well. And then based on the type, there's the common location that these occur. So type 1 is the distal lesser curve, type 2, distal lesser curve and a duodenal component. Type 3, pre-pyloric, pretty self-explanatory. Something to make note of, as I put in the table there, type 2 and type 3 are associated with hypersecretion, and I know mine is blocked by the pictures here, but if you move that, you'll see which ones are associated with your hypersecretion, which again are type 2 and 3, and then 1, 4, and 5, which are not. Type 4, associated with the proximal lesser curve of the stomach, and then type 5 is drug associated or NSAID associated, and so those can occur anywhere within the stomach itself. And then I put on a secondary table. Both of these tables come from Cameron's that kind of identify where it's located, the cause, and then based on that, what is a procedure that the literature or Cameron's had recommended. And something to make note of here, as we're not going to touch too much on those, are type 2 and 3, where they talked about doing vagotomies, and then there are the different type of vagotomies, whether it be truncal, proximal, or highly selective, and then pairing that with a distal gastrectomy, and then possibly doing a Billroth 1 or Billroth 2, depending on the patient. And then there are some other recommendations. Given our current patient coming in, he's in the late stages of phase 2 with what sounds to be a type 5 ulcer. We're going to most likely move towards a gram patch or a patch at the current time, with possible intervention depending on how that patient proceeds after that initial surgical intervention. Oops, sorry about that. So the ER gets back to us, let us know that our initial set of labs, not all listed here, some of the other things they would get are like a cardiac panel, but otherwise they call you and let you know the BMP and the CBC come back, and the only thing they note is a mild leukocytosis. And so up to date, Cameron's and Sabison's all kind of make note that the most common lab to come back abnormal with perforated gastric ulcers are mild leukocytosis or moderate leukocytosis. Usually you don't note other changes in labs within this window. Something else that they could have sent or we would have recommended, even though this is more of an ED presentation versus an outpatient presentation, is doing a urease breath test or stool antigen. They talk about the 1-hour testing, but depending on the patient presentation, we might not have that back yet. So it would be something that we'd have to look at in a follow-up basis. And so something to make note of with these H. pylori infections is that patients will often manifest mild to moderate inflammation across the entire stomach, as well as they might be on current therapy, which will affect how you're going to treat, or the testing may result for the patient. Remembering that if they're already on a PPI therapy in a clinic setting, it's beneficial to stop that for 1 to 2 weeks prior to testing, as that may affect your results. If the patient is on an over-the-counter bismuth or happens to be on antibiotic therapy as well, we may need to hold those for up to 4 weeks prior to testing, as those can also alter your results. So letting the patient know that, hey, we're concerned about H. pylori, testing may be skewed, we'll need you to stop these. You may experience some discomfort and pain while we're getting ready to test, is something that they should be aware of. And then based on their other comorbidities, we want to make sure we're ruling out other possible causes. I have endoscopy on the bottom of the slide. On an outpatient basis, whether you've done H. pylori treatment or not, which H. pylori treatment, as you remember, is that triple therapy of the clarithromycin, ampicillin, and then a PPI agent. Treat them for the 2 weeks. They continue to have issues, so you may want to follow up with endoscopy, look at the ulcer, biopsy that, and then pending what you find there, do surgical therapy. Otherwise, the ER notified us that they had an upright chest x-ray, CT, and then an upper GI study. The most common finding on your upright chest x-ray is going to be air under the diaphragm. Problem with this is it often only shows air under the diaphragm in 50 to 75% of the cases for gastric or duodenal ulcer perforations, with a secondary downside of it doesn't really help you localize, is this truly a perforation or is there some other pathology going on with this patient?
Hold on a second, Brandon.
Go ahead, sir.
Barrett, are you online?
Yes.
If you had this presentation that Brandon put forth and of the patient presentation and this x-ray, would you take them straight to the operating room? Hemodynamically, okay, tachycardic to 110, blood pressure is 110 over 60. Fairly stable, no pressors, responsive fluid.
Yeah.
Just curious.
Yeah, with this x-ray, I would take him to the operating room for a presumed perforated viscous. I would, just with this x-ray.
Okay. Anybody else to get a CT? Dan? You look skeptical. Aaron? Do plastic surgeons order CTs?
We do occasionally,
Okay.
just before we consult someone else. But in this patient, I would just take him back. I mean, it would be nice to have a CT just to have an idea of where the perforation is, but there's one somewhere, so I would just take this guy back.
Yeah, I think it's reasonable. He's got the NSAID use. He's either got osteo or low back pain. But if he didn't have something like that, you may want to get it just to, what if it's diverticulitis, one of the other things. So anyway, just curious, my own edification.
So as I was saying, though, unfortunately, that still leaves 50 to 25% of cases where an upright chest x-ray might not show air under the diaphragm, or maybe we weren't able to appreciate it. So as Dr. Bell was alluding to, moving on to the CT. And so this has better sensitivity and specificity for identifying extraluminal air and then possible extrav, suggesting again that we should take this patient back. And then the third imaging modality that they recommended was the barium study or the upper GI study, where you may see the crater sign. And I'm not sure if you can see my mouse at all, but here within the duodenum, and then better shown in the stomach here, where you have two craters that lead to the mound or point to the mound. And then depending on if the body has created its own gram patch or it's an ulcer itself not yet perforated, that's where the mound is. And so we can identify that here with the red arrows that they're showing, or you'll see extract coming from that mound showing that you've had the perforation.
Yeah, I would say that barium is a great study for ulcer disease that's not perforated.
Perforated.
However, if you think it's perforated, I'd use gastrografin or something.
In the water, yep.
If you've ever had the opportunity to operate on somebody with barium all over their cavity, you'd like not to repeat that experience.
I don't know if any of y'all were with me when the X-ray tech on the weekend did the small bowel follow-through with barium on the old guy. His last name started with a D. He was 88. He knew Dr. Hetz. He was one of these old hospital dental guys. And it was the greatest disaster I've ever had a part of. So shy away from barium, please, in the acute setting.
All right. So as we're letting the OR know, hey, we're getting ready to bring this gentleman up from the ER, prepare him for admission. Some things we want to let the ER know we want to get started include IV fluids, placement of an NG for decompression, an IV PPI like Nexium, hold whatever offending agent they may have. Obviously, this is going to have an immediate concern, but moving forward, we'll hold this and then let the patient know on the long term that he should have his primary care manager alter his regimen, and then getting them on some antibiotic therapy to cover gram-negative rods, oral flora, anaerobes, and fungus. So that'd be a regimen like ampicillin, metro, rocephin, and flagyl in the preoperative and perioperative window, excuse me.